Good afternoon, everybody. The case for discussion for today is endogenous endophthalmitis in a patient with myasthenia gravis who was treated with rituximab. Myasthenia gravis is a chronic autoimmune disease mediated by antibodies against acetylcholine receptor, muscle-specific kinase, or other proteins in the neuromuscular junction. Treatment is usually immunosuppressant like steroids, azathioprine, mycophenolate mofetil, but 15 to 20% of myasthenia gravis patients are refractory to immunosuppressant. In those cases, rituximab is a monoclonal antibody against CD20 B lymphocyte, which is considered as an alternative in these patients. Endogenous endophthalmitis is a rare sight-threatening blood-borne infection from primary site elsewhere, commonly affecting immunocompromised patients. The prevalence of endogenous endophthalmitis in South Indian population is found to be 2.6. In the case proper, the patient present is a 45-year-old male who is a known case of generalized myasthenia gravis, status post thymectomy, and was already on intravenous rituximab. At the time of presentation, the patient was already empirically on vancomycin and piptas in view of abscess over the right side of scalp since 1 week and multiple vesicular lesions over his left arm since 2 weeks. Our complaint was a complaint of decreased vision in the right eye since 4 days, which was associated with pain and congestion. On evaluation, visual acuity was counting fingers at 1 meter. Anterior segment showed lid edema, circumcorneal conjunctival congestion. Corneal edema with keratic precipitates and streak hyperpion was noted in the anterior chamber. Posterior segment evaluation showed grade 3 vitritis, along with an elevated yellowish lesion noted supranasal to the disc, extending from 12 to 2 o'clock, which raises suspicion of a subretinal abscess, and the diagnosis was confirmed on B scan, which showed a dome-shaped elevation with heterogeneous echosity superior to the disc. For the same, the patient underwent plasplanar vitrectomy with silicone oil tamponade, and intravitreal injection of vancomycin and ceftazidime was given. The subretinal abscess was not drained in order to prevent any iatrogenic breaks. With this diagnosis, the patient was started on topical and systemic antibiotics along with oral steroids. Concurrently, the patient developed left-sided weakness and MRI brain was done, which showed diffuse ring-enhancing lesion, which was suggestive of cerebral abscess. Culture sensitivity of blood, aspirate from scalp abscess, and vitreous humor showed nocardia fascinia, and the patient was found to be more sensitive to intravitreal amikacin. So, intravitreal injection was given, systemic antibiotics were changed, and a total of ceftazidime and meropenem 7 doses, and amikacin was given for 2 doses. At 1 month follow-up, the visual acuity had improved to 6/36 with complete resolution of subretinal abscess. So what is unique in my case? Even though aminoglycoside class of antibiotics are known to precipitate myasthenia crisis, we preferred giving intravitreal amikacin under close systemic monitoring. Endogenous endophthalmitis post-rituximab infection has not been reported so far. Clinical implication, subretinal abscess is a rare condition and difficult to treat. Nocardia is notoriously associated with abscess formation, making it an important consideration in the divisional diagnosis. So the take-home message in this case is that endogenous endophthalmitis in immunocompromised is not uncommon, but early diagnosis and treatment can save vision. Clinical microbiological correlation is crucial for effective treatment, and not all abscesses require drainage. Thank you.
How do you differentiate endogenous from
So based on the systemic presentation, sir, because in this case the patient had infections in other side which was suggestive that it could be endogenous. There was no history of any other ocular trauma or anything which suggested exogenous origin.
So in this case, how do you think that is endogenous?
Sir, it could be either due to the scalp abscess, and the patient had a cerebral abscess as well. And the scalp abscess showed nocardia, and even the vitreous sample which was collected also showed sensitivity to the nocardia. So it could be secondary to the scalp abscess. The patient could
have you cultured vitreous samples?
Yes, sir. That showed nocardia, which was sensitive to amikacin. Okay. Thank you, sir.